Good afternoon, everybody. I am going to introduce Dr. Janice Knoefel. Dr. Knoefel has an MD and MPH, is a professor of Neurology and Internal Medicine in Geriatrics at the University of New Mexico. She graduated from Ohio State University of Medicine and trained in internal medicine, neurology, geriatric neurology, and public health. She has been on the faculties of the University of Cincinnati and Boston University. At the University of New Mexico since 1996, she is active in clinical care, teaching, and research. She is clinical director of the Center for Aging, Memory and Aging Clinic, and administrative core co-director of the NIH-funded New Mexico Alzheimer Disease Research Center. And she's also a key collaborator with us at Seniors Clinic, and we always appreciate her expertise. And with that, Dr. Knoefel, I'll turn it over to you.
All righty, Chris, thank you so much for the invitation. I do appreciate it. Let me see if I can share my screen.
And now, take it away.
This is what I get for having two monitors, right?
Exactly.
Okay, well, thank you for that little distraction. I have way too many slides. I know you've heard that before, but let me just get started. So we're talking about the basics of dementia and then some, and I'm going to be giving an update on the newly released Aducanumab at the very end. Our learning objectives, let me start with a definition. Impairment in at least, and again, this is the neurological definition of dementia, okay? Impairment in at least two cognitive domains. They're listed here, represents a decline from the previous level of function, and it interferes with our daily function and our level of independence. Of course, you've heard about the famous neurology rule out. We have to rule out a number of other conditions, including psychiatric disturbances, delirium, systemic disease, and other neurological problems. Demographics, that's partially why I got my MPH. Learn about a lot of demographics here. Age is the biggest risk for dementia. It increases drastically with age, so the incidence increases drastically, and also the prevalence increases as well. Believe it or not, the incidence rates for men and women are roughly equal, although since women are living so much longer than men, at least currently and in the past, we see a lot more women on average, just because of the sheer demographics of the overall population. Current estimates are about 5 million for Alzheimer's. And whenever you hear anybody talking about Alzheimer's, if you want to understand the full impact of dementia, just double all of those numbers, because the other dementias also contribute quite dramatically to those numbers. We know that we're going to be seeing a tsunami of Alzheimer's disease and dementia. I'm sure you've been reading about that, and we're certainly seeing it in clinic, unfortunately. So this is what the prevalence figures look like. It just keeps going up and up and up. You think that maybe we would spare some of our very elderly, but no, it just keeps on going up. These are the risk factors, other than age. Vascular is probably the biggest one. And there's a lot with the vascular factors, including things we can do something about, namely control the hypertension, treat the sleep apnea. There are some other factors we can't do anything about, which is remote history of smoking. Okay, that also still counts as a risk factor. The presence of prior brain trauma and alcohol overuse. And I know you see a lot of this in your clinics, for sure. Trying to talk people out of using alcohol, period, is a huge task. Medications can also be risk factors. In particular, I'm going to focus in predominantly on the anticholinergic medications. And again, anticholinergic. We know that for the most part, memories are formed by the cholinergic system. So if we're taking a lot of anticholinergics, you can expect to have an impact upon your memory. In fact, if a person takes regularly, consistently strong anticholinergic, be it for bladder control or control of allergies with diphenhydramine, if you take a substantial regular dose of those medications for 5 years, you have just doubled your risk of Alzheimer's disease. It's pretty dramatic. Some of the symptoms, again, I know these are very, very familiar to you, in particular, poor performance and work at home, difficulties with bill paying, taxes, and business, because those are the most difficult things we do in general. Also, I'm going to emphasize a little bit driving. Driving is also, although you might think that you're always on autopilot, hopefully you're not always on autopilot. You know, you can get yourself into trouble. In particular, if you're having a memory issue, you can lose the car, or you can get lost while driving. I have a crazy joke about, you know, all the little vehicles that drive you around in the big Walmart parking lots for security, quote unquote security. Well, they're really helping people locate their cars in a very large parking lot. If a person develops aggressive or risky behavior, that's more or less executive function as far as the driving goes, and poor mental map, knowing where you want to go, knowing where you are, but not able to really find your way driving, that would be a visuospatial deficit. Other symptoms include change in affect or emotional control, certainly change in hygiene, clothing choices, and episodic confusion or anxiety. Really think early on about dementia with Lewy bodies. A clinical interview, we need to hear, as I'm sure you do as well, you need to hear more from people other than just the person. We need to hear the person, listen to the person, but we also need to hear from family and friends. In some cases, we have employees being referred for evaluation. And in the past couple of years, we've actually made a major connection with some of the state's professional associations for individuals who have a high level of training and have a very complex job with a lot of responsibilities, be they physicians, JD, CPAs, we've even had some judges. So we all deserve a real evaluation. And so in addition to hearing observations from these individuals, we also need to understand what are some concrete examples, like give me an example of what you were observing. And that can also key you in possibly as to what specific domain they're having difficulties in. It's good for us to understand the pattern of symptom onset, and then of course the time course. Has it gotten better? If it's getting better over time, it's either a difficulty with observation or it may indicate a affective disturbance. Generally, we expect that the dementia symptoms will worsen over time. So again, working towards the dementia actual diagnosis, observations are not enough. We need to document a decline in their function, and we do have scales for doing that. This is actually something that we have borrowed. I mean, the field of dementia care has borrowed from the geriatric world. So we kind of categorize function into either community activities, which generally is referred to as, quote, the instrumental activities of daily living. But then we also, of course, have self-care activities of daily living. Early on, we're going to see more impairment in those community activities because that's the higher level, and generally 100% independent function. And then self-care impairment comes on later. So here's a list of all the things that we query the patient and family about. The instrument itself is called the FAQ, Functional Activity Questionnaire. And again, this is, I can give you a copy if you're interested in checking this out. So it checks off these various categories of function. And I would just highlight to you that taxes and finances, those are, a very high level functions that an individual engages in at least once a year because we have to file our taxes. I had a very wonderful mid-90s tax accountant who was sitting in my office because his family had found out that he had not filed taxes in the past 5 years. So that was a big red flag for them. And then the other activity that we've also talked about already is that of driving is often affected early as well. So going on to the self-care activities of daily living, bathing, dressing, grooming, toileting, feeding, ambulation. We have a scale, we call it the PSMS, it's the Physical Self-Maintenance Scale. Again, I can give you a copy of that if you're interested. Generally, once a person is mid level of dementia, we start getting into some difficulties with self-care activities. So we have observation noted, we have decline in function noted, but yet now we have to understand that these changes are referable particularly specifically to a decline in cognition. So here's where the actual examination comes in. We like to group the cognition into the different domains that we have here. Attention executive are grouped as one, memory, language, and then visual spatial. And of course, we're always looking for affective disturbance. It's part of the usual exam. For the cognitive domains, we in clinic, we use the standardized tests. They're standardized and validated according to your age and education. So we can give you not only that you are impaired, but we can give you a standard deviation as to how far or above average that you are. So that's very helpful to, number one, make the diagnosis. It's also very helpful in following individuals to see if they're actually worsening over time. Again, these are the domains. This is how we test them in clinic. Again, executive function is one of the four lobes of the brain, but it gets more than its share of real estate. It gets 40% of our brain power is executive. And this is exactly what we test in clinic. The characteristics are listed here. How we test this is a neuropsychological test called Trails A and B. You probably are familiar with this. It's a timed task of tracing a trail, if you will, from in the A, it's just the numbers, A, B, C, D, just the numbers 1, 2, 3, 4. In B, you have to alternate between a number and a letter. So that's definitely a higher level of function. And it's easy to see how it's easy to see people when they mess up on that, when they start to make errors. So again, this is we have a quantitative assessment, and we also have a qualitative assessment. So a quantitative is how fast you can do it. Qualitative is how many mistakes you make. Memory, multifaceted, so hence we test memory in a multifaceted fashion. Explicit memory is what we call the conscious level, which means that that's what we talk about. We talk about facts, we talk about politics, we talk about sports, et cetera, et cetera. We also have implicit memory, which is the subconscious, the non-conscious level. And the best example I can think of is riding a bike. It's motor memory. Once you learn how to do it, you don't have to think about doing it anymore. If you do have to think about doing it, then that makes me a little worried that something is going on. So the processes of learning involve encoding and acquisition of knowledge, which means to me, I have to boil these things down into simple terms. Encoding is getting the information in. Keeping it in is what we call consolidation of memories. And then the retrieval of memories is getting it out, which means that I can test all three of these processes in clinic. The routine one that we use, we don't actually test nonverbal learning. We rely very heavily upon verbal learning. And the Hopkins verbal learning task is a 12-item verbal recall test. Language, again, most of our work life is taken up with language skills, and so we measure all of them actually. Auditory written comprehension, repetition is measured by the Boston Diagnostic Aphasia exam, naming and vocabulary measured by the Boston Naming Task, FAS, and also animal fluency. Writing and reading are also sampled in clinic. And then we make a lot of professional personal observations, which is how is the individual's fluency? How about narrative speaking? The old, come into the doctor and say, well, tell me what happened. Well, you're testing their narrative speaking abilities. Well, I'm also listening to speech production and the actual articulation. That's not particularly a quote cognitive function, but is certainly a neurological function. So that can help key us in if there are other difficulties, such as either white matter changes from the vascular factors, or perhaps an actual stroke. And of course, very, very important also the social aspects of language, the turn taking, hopefully no interruptions, etc. That can be sometimes the key to frontotemporal dementia. We test the visual spatial abilities, and this one we kind of rely more upon patient and family report, but we do have in clinic, we do have the individual drawing us some pictures. The real test of visual spatial has to do with such things as dressing. If you've ever noticed a 2-year-old trying to put their own clothes on, you're getting a lesson in actually visual spatial learning during that process. Pathfinding in the community and home is usually by report of family. I recently had one person who was having trouble finding their way out of a single room. Again, very, very disturbed visual spatial functions. And of course, we've already mentioned a little bit about driving. Again, that's our best way to practice our visual spatial skills every single day. Somebody has done some studies looking at all of the behaviors that go into driving, and of the 37 of them, I believe 22 are visual spatial functions, and some of them are listed here. In addition to the cognitive abilities, we also need to make a judgment as to the emotional state of the individual. Of course, we know in general, older adults can regulate emotions better than young individuals, due to in part maturity and also life experience. So that's the good news. The bad news is that older adults definitely have a higher incidence of depression and anxiety symptoms, which they may or may not actually even recognize. So in assessing cognition, we always need to address the emotional state, since these functions are very interdependent. So other than observation of affect and family report, we actually do test with the geriatric depression inventory. We use the 15 item form. And if people have trouble answering these questions in the yes/no format, and they're internally debating, generally I put that down as a point for being depressed or anxious. If they can't say definitely one way or the other, they're equivocal and they're going to get a point for depression. Anxiety, we're using the GAD 7 scale with the 7 domains and four choices. And again, that's pretty straightforward. That's very standard. So basically, we use the neuropsychological based testing for what is expected for age and education. And so based upon the actual pattern of deficits in the cognitive domains, with additional input from the clinical history, the neurological exam, we posit potentially a diagnosis of dementia. In general, and again, I don't need to tell this audience, dementia generally is underrecognized and underdiagnosed. So we have our work cut out for us. So here are the choices. Sometimes when we have trouble making a decision, we say, okay, so what are the choices? Give me some choices. So here are the choices pretty much in memory and aging clinic. So you can be normal, you can be depressed, you can have some self-reported change in your cognitive abilities, but we can't find them when we do all of this previous exam. You look pretty darn normal to us. So we have a term for this, and that's an accepted term for coding. It's called subjective cognitive impairment. We also, of course, have the mild cognitive impairment and dementia level. So those are kind of our categories. So let's talk about how we can operationalize that. So this is a bell-shaped curve of normal distribution, not unfamiliar to you. So we have categorized average as from -1 to +1 standard deviation. So most of us are average. Two out of 3 of us are all average. Once we get further out, either on the positive or the negative side, so from from -2 standard deviation to +2 standard deviations, that's 95% of us. So how we operationalize our cognitive deficits is if you're from -1 standard deviation to -2 standard deviation, so you have a mild measurable deficit in that cognitive domain. So that's what we call mild cognitive impairment level of deficit in that particular cognitive domain. So if we take that further, again, from -3 to +3 standard deviations, 99.7% are going to be within those -3 to +3 standard deviations. We operationalized a dementia level deficit in a cognitive domain as being -2 standard deviations or worse. And that, again, that gives you a dementia level deficit in that particular cognitive domain. So here we go. So we've done the cognitive testing, and we have one or more deficit that is a -2 standard deviations or worse. And we have documented a decline from a previous level of function. Then we propose a possible diagnosis of dementia. What additional information we use to help us? We look for some signs on a neurological exam. We're looking for such things as cerebrovascular illness, which would give a facial asymmetry, posturing of outstretched hands, or on the stress gate. We can detect some abnormal posturing when we are having individuals do some challenging motor tasks. I'm also looking for a unilateral and asymmetrical sensory deficit, indicating possible underlying cerebrovascular problem. And of course, asymmetrical reflexes, predominantly hyper reflexes on one side versus the other, and maybe a Babinski or equivocal Babinski. A balance and gait, we're looking again very carefully, because balance and gait is going to be much more related to actual white matter changes in the brain. And such things as the flex posture, multi-step turn is also helpful, and impaired tandem. Now, a lot of our individuals do have that in peripheral neuropathy, so we have to factor that in as well. On the tone exam, we're looking for some signs of either Parkinsonism, such as the cogwheeling, or Gegenhalten is much more indicative of a frontal lobe or diffuse white matter problems. So it can be very helpful in putting forward a particular diagnosis. So we've done the first step here. We've got the clinical interview. We've done the cognitive, physical, and neurological exams. So now we're going to move on to the structural imaging. Structural imaging, for the most part, is most valuable in assessing what has been the impact of vascular factors. It comes as no surprise to you, I'm sure, that many individuals have, at times, in some instances, multiple small lacunar strokes, and they've never had a clinical event. So we're looking for small strokes. Occasionally, we'll find a surprise with a large infarct, perhaps on the right side, but that's pretty unusual. By labs, we're also doing a lot of rule outs. We want to make sure they're not deficient in vitamin B12. We want to make sure the thyroid is functioning right, and it really is also helpful to understand what the kidney status is as well. So with all of this information, we can start to propose a dementia type, and this is it's important to have a working diagnosis, because it will help guide our treatment and help to establish a prognosis so that we can discuss it in a reasonable fashion with the patient and the family, and also potentially help to determine future care venues. Individuals, particularly with frontotemporal dementia, generally will need a professional care setting sooner than many other types of dementias. So let's move on to treatment a little bit. This part's generally pretty quick because we have some general treatments, but nothing really specific at this point. So the treatment of dementia really does depend on the cause. If we are positing a progressive dementia, there is no treatment to stop the progression, and there's certainly no cure. We have some medications that may temporarily improve dementia-specific symptoms, but over time, the individual is going to continue to deteriorate if our diagnosis is correct. Antidepressant therapy, again, not too far afield for this group. Antidepressant therapy can really do some magic, can work some magic. Even in people who have dementia, if they're having some depressive symptomatology, it's always good to go ahead and treat. And of course, we have a fair number of secondary symptom treatments too. So these are our classes. This is the first class of medications. This is not new to this group. It works on the underlying acetylcholine pathology. It doesn't really work on it. It just kind of temporarily increases some transmission, but the pathology, the amyloid pathology continues. We always try this class of medicines on people. I generally start with extended release preparations, just because so many of the older people have GI disturbance with these medications. Some even have intolerance, even at the extremely lowest dose, even of the extended release. So this is not for everybody. I should tell you, in many instances, the individual may stabilize on these medications, and the patient and family will come back and say, well, I don't really think it's doing anything for me. I don't think it's working. And in reality, if we take the medication off and they kind of nosedive a bit, then we say to ourselves, aha, it was working. So we end up putting people back on them. I generally don't do that. I just keep people on it, and even if they are declining. There's a titration to all three of those medications. Galantamine needs renal adjustment, so the middle dose is the max. And again, these are old medications. Again, some little clinical pearls here. If the person's having vivid nightmares and you're giving it at nighttime, put it in the morning. They won't. Their dreams, their sleep will improve. Always monitor for weight loss over the long haul. In individuals who are already having cardiac problems, I tend to stay away from these medications. It can exacerbate underlying urinary control issues, and occasionally we'll get a skin rash for some of the for the patch with the rivastigmine. Again, another class of medicines that was approved almost 20 years ago. This is routinely used. Again, it's a titration as well. I actually have seen slightly better activating effect, a little slight antidepressant effect from this medication, but again, I routinely use it as well. Some other symptomatic treatments, okay, if they're using alcohol, tobacco, or caffeine, we need to really taper and get people off of these medications, off of these substances. We don't know what effect it's having without taking them off, especially the alcohol. People, we should not have our older individuals with cognitive decline still taking alcohol. And of course, we need to really get off of the benzodiazepines as well, anticholinergics, and I've already talked about the antihistamine meds. We need to try to control all of those medical conditions, and this usually means getting the family involved, in particular if it's diabetes or something like that. Keep people physically active and constructively occupied. I also want to make a pitch. I tell my patients and family all the time, my main job is to keep people out of the hospital, because once they go into the hospital, their function and generally their cognition just nosedives, and they may not get back to their pre-existing, to their prior function. And please refer to the Alzheimer's Association. I want to tell you, and I know you know this, they do all the dementias. It's not just the Alzheimer dementia that they do. And they have support groups for, frontotemporal, for Lewy body, for vascular. I mean, they have a lot of good programs that our patients and families can really benefit from. So these are a list of some of the more prevalent subtypes of dementia. I'm going to spend a little bit of time on a couple of these, and then I'm just going to go right on into the new treatments that has been approved. So Alzheimer's disease, you've seen this slide previously. So basically, the progression in Alzheimer's disease is based upon amyloid progression that we can see on the scan. Sometimes, in many instances, that subjective cognitive impairment person's coming in and you follow them long enough, they deteriorate, and you just say to yourself, I know this is going to turn out to be Alzheimer's disease. And again, we've looked at these before. And this is a repeat slide. Okay, so we're looking potentially at individuals who do have a family history. I want to just say that the family history is overdone. The far majority of our Alzheimer cases are still considered to be sporadic. If there is a deterministic gene, which happens to be one of the presenilin genes, and there are a few other ones, and we are discovering more. But for the most part, the Alzheimer occurrence is sporadic. So the risk is negatively associated with a high index of depressive or anxiety symptoms, which means that if the individual is having a lot of depression and anxiety, chances are they're not going to turn out to have Alzheimer's disease. Chances are. And when we get to this point of examining individuals, again, it's an opportunity for us to engage, to help correct some perhaps bad habits that they have developed. But number one, I don't say there's nothing wrong with you, come back in 10 years. No, I say, if you're worried, I'm worried. I want you to work on all of these things, and then I want you to come back and again in 1 year, and we're going to go through this whole evaluation again, so that we can see if they are declining or if they're improving, or exactly what is going on. So it's establishing that clinical relationship that's very important at this stage. Now, as we advance, the amyloid advances, what do we get into? Again, this is important, a point that the symptoms may or may not be self-reported. Many times our patients are brought in by their families and say that I don't know what's going on. They're not being able to do the things that they used to do in the past. Again, a definition of mild cognitive impairment implies that the function remains fully independent. And this is the big distinction between dementia and mild cognitive impairment. Their function is still independent. We're starting to see some differentiation as far as some of the underlying etiologies. So not everybody has amnestic mild cognitive impairment, amnestic being that your memory cognitive domain is impaired. We are seeing other what are referred to as non-amnestic MCI. If it's language, then we have two different Alzheimer's disease language variants. If it's visual spatial, think of dementia with Lewy bodies. Visual spatial is impacted very early in many people with DLB. Executive function can also be affected in dementia with Lewy bodies. But if we see a prominent executive dysfunction, we actually think of vascular MCI. Because again, all of the white matter is being impacted, and that just by mass alone affects more the executive function than the others. And of course, very, very common also is the mixed deficits. Generally, that's going to turn out to be vascular layered upon Alzheimer pathology. So again, we have an opportunity. We're going to help clean up their lifestyles, get rid of the alcohol, treat that obstructive sleep apnea, and I'll see you again in a year. We'll go through this whole thing again. And then we move on to, again, a more progressed stage of Alzheimer's disease, which is, again, based upon further a deposition of the amyloid proteins. So this is where the deficits have worsened, -2 standard deviations or more, and that's a dementia level impairment right there. At this point, the function in the instrumental activities of daily living is starting to deteriorate, and the person is becoming more dependent upon family. Generally, by this point, they're not still working. Generally, although you might be surprised. Alzheimer's disease itself, the classic presentation is that of amnesia, major memory impairment. However, there are other cortical symptoms, as I have already mentioned, can also be primary, such things as primary progressive aphasia. And there also is a visual spatial variant as well. One of the first Alzheimer patients I ever saw when I was an intern was a dentist who was being referred in because he could no longer do his work. That dentistry and many other professions rely very heavily upon visual spatial function. That was his presenting symptom for his Alzheimer's. Other symptoms include, as listed here, anomia, agnosia, apraxia. All of those are the cortical functions. Social behavior is often preserved early on, and of course the motor function is usually normal as well. Many of these individuals do not have significant vascular problems yet. Okay, and I'm just going to go right by this because we have more to talk about. Again, if we diagnose Alzheimer's, that still gives us this opportunity to improve many of these other problems. And then we also plan to start the FDA-approved treatment. So I'm just going to say a few minutes here, talk a few minutes about Lewy body dementia, because this is, I think, becoming more and more recognized over time, certainly over time. When I was in training, we used to call it Alzheimer's disease with extrapyramidal features. And if we had really tested these people in detail, we would see that their cognitive profile was very different from an actual Alzheimer patient. There's a number of different names, as you can see here. And the question is it several diseases that have a shared finding of cortical Lewy bodies versus is it a single disease across a clinical and pathological spectrum? I think we're going to find out that it actually is a number of different diseases, but with that shared finding. I'm not working in this field myself, but I'm really an observer. So here we go, the evolution of the concepts. Neurologists, when I was training, we used to call it Alzheimer's disease with extrapyramidal features. Although if the individual presented with more signs of Parkinsonism, you could become very quickly very psychotic with trial of carbidopa levodopa. That was another one of a traditional, not unheard of presentations. Psychiatrists were reporting late onset psychosis, but the Parkinsonism was drastically worsened by neuroleptics. I mean, to the point where on a ventilator in the ICU, extrapyramidal. And then pathologists, of course, are trying to help us figure out what's going on. And, we've got Lewy bodies being reported as part of Parkinson's disease, which we already saw that slide. And also what used to be called the Lewy Body variant of Alzheimer's disease. So you can see we were kind of muddled back in those days. Now, I like to make the analogy of dementia with Lewy body to this very famous poem, Six Blind Men of Indistan. And there's a dozen or more other stanzas, but this is the last one. So this is a story of six blind men, and they were trying to figure out what is an elephant. And each one took a separate observation, if you will, and they tried to understand. So the gentleman who was sitting on the ground and feeling the leg, he said, well, an elephant is very much like a tree, because he was feeling like the leg being the tree trunk. Anyway, this is how in the past 50 or so years, physicians have been trying to figure out what is Lewy body, and this is kind of what we were doing. So this became much more clinically evident with the coming of the immunohistochemical stains for the Lewy body. Again, it was mentioned, it was noticed very early on in Parkinson's disease because it was easy to see. But we know that there are cortical Lewy bodies also that we're now able to see with the new staining techniques. So this concept is still in evolution, I can tell you. So again, this is Dr. Lewy is the young gentleman on the far right side, and this is a picture of the Lewy body pushing aside the neuromelanin in the pigmented cells of the substantia nigra. So you can see it would be much easier to see there. So these are, again, very complex illness. There are a lot of different symptoms here, core features, suggestive features, and of course, these things have to be accompanied by progressive cognitive decline. So this is our differential diagnosis. It's quite extensive, and this is why we need to develop long-term relationships with our patients so we can help document and interpret these symptoms as they develop over time. I'm going to say a few things about the REM behavioral disturbance that we routinely see. And again, this is, it's puzzling to try to sort out. So we know that visual hallucinations in dementia with Lewy body, that's actually not psychosis, but it's actually REM intrusion in the waking state. We know it's very well documented, both with my own experience and in the published literature. Hallucinations are much worse with sleep deprivation, and that's because there is no REM, and then the REM intrusion is happening more frequently in the waking state. The best treatment is sufficient restorative sleep. So that's what the main treatment target is to get that improved sleep. The psychotics are generally ineffective, and other than perhaps to provide some sedation, which may result in some sleep with kind of an indirect improvement in the person's state. And that's why individuals with Lewy body, they change dramatically from one week to the next. And that's because the hallucinations really do account for those wild fluctuations. We also know that there is extreme sensitivity to the antipsychotics with, again, dramatic worsening of the Parkinsonism. And, we don't see this kind of reaction in Alzheimer's disease. It's really, it's almost like it's a stress test for dementia with Lewy body. So let me just give you another little historic background here. we know that sleep deprivation is a topic for history, but it's also a current topic for discussion. And this goes all the way back. The first reported cases actually in 16th century Scotland. They were on the witch hunts, and but they couldn't do anything unless the person confessed. So how they coaxed the individual to confess was it was a process called waking the witch. So you deprive the person of sleep for days, resulted in hallucinations, and then what was said and done during the hallucinations were interpreted as confessions, and that resulted in a conviction. So most modern day neurologists and sleep specialists would have diagnosed REM intrusion into the waking state. And this is pretty much what we're seeing in Lewy body. If severe and prolonged, actually we would label those episodes as psychotic. But unfortunately, we know that sleep deprivation, even to this day, is a technique of torture. And sleep deprivation can cause death. And we know this to be the case because there's a neurological condition called fatal familial insomnia, which is ultimately does result in death, and it does cause hallucinations as they go along. And now one slide for a short regression here, okay? Restless leg syndrome. The definition of restless leg syndrome is that is unpleasant, uncomfortable, subjective urge to move the legs while awake. The individual is awake. There's a sleep so restless leg syndrome is not a sleep phenomenon. The individual is not asleep. We do have something called periodic limb movement disorder, which is sleep-induced disturbance, and this again can be seen on the sleep studies. Fidgety adults, fidgety children grow up to be fidgety adults, and they may be misdiagnosed as a restless leg syndrome. So the point that I'm making in reference to Lewy body is that REM behavioral disturbance is often misdiagnosed and mistreated as restless leg syndrome. And we know, if you read anything about restless leg syndrome, that everybody likes to use the dopa agonists, but dopa agonists given for what is a supposed diagnosis of restless leg, it might exacerbate. In fact, it does exacerbate REM behavioral disturbance. So I just point that out. And I am going to kind of go right by this. I just wanted to give you a little case, which actually I worked with your department, Chris, with this young lady. Is 64 years old. She was a Child Protective Services caseworker who self-retired herself because she was having difficulty navigating in her car to rural visits. So think visuospatial. She was diagnosed and treated by me here as an outpatient, worsening symptoms, and this is again over a number of years. Worsening symptoms prompted a non-UNM behavioral health stay inpatient. She was treated with an antipsychotic for 2 weeks. She was discharged in a improved condition. She was unable to walk, unable to talk, unable to swallow. She was discharged home to hospice. And the family was in contact with me, and I said, no, this can't be accepted. So I was able to get her in to our UNMH behavioral unit where meds were adjusted. She went home, she improved, she went back to her baseline, improved, went home. And she's been home for 1 year. She's still progressing, but she is at home and family's taking care of her. And just a few other minor points about vascular dementia. I'm going to go right on that one. Vascular dementia is pretty common. It's not usually by itself. It's usually in association with Alzheimer's disease, and that's what we call mixed. So again, I'm going to go right by this per se. So treatment of vascular and mixed dementia, again, all of these things that we have seen before. And I'm going to spend the last few minutes here on the new therapy, the new Alzheimer therapy. So the antibody is called Aducanumab, trade name is Aduhelm, and it was approved by the FDA in June of this year. And the approval is very controversial, as you know. Approval was based upon improvement in the PET-CT appearance of amyloid. As you know, in general, as scientists, including public health people, we like to see improved clinical markers, function, or cognition, not an imaging proxy. So we have had a lot of difficulty with this. Currently, we're planning on. We are investigating prescribing and administering this medication. We have not treated anybody at this point. There's a lot of difficulties here. So you've heard about the cost, but that was just the cost of the medicine. So there is extensive PET-CT scanning in the first year, up to a total of 7, because one has to monitor for side effects of the treatment. The monthly infusion itself is fairly expensive, the administration of it, and then we have the follow-up medical care. Side effects, it's expecting treatment and side effects in up to 35% of people. I want to point out to you that amyloid PET-CT scans are not currently available at UNM. The isotope needs to be flown in from Arizona, so we don't really we're planning, but we're not there yet. There have been a number of national healthcare systems that have decided not to offer it, and at least 3 of the insurance funders have said that they're not going to pay for it either. So this is kind of the bottom line right here. The biggest insurer of older individuals who are going to be eligible for this medication is Medicare. The Center for Medicare and Medicaid has established its review committee. They've established their process. We are expecting a national coverage announcement sometime in January of next year. And the final rules, which is when people then start using it, is going to be potentially mid-April of this year. And then the newsflash from this week, unfortunately, the first fatality from clinical treatment has been reported to the FDA. So we'll see where this gets us. So currently, we're undertaking preparations and we're exploring the logistics. No decision will be made before the CMS policy is in place. I just wanted to point out to us also, the policy of the P&T committee is that no therapy will be approved for use at UNM unless and until public funding is available. So we're not going to be, one of the, the Gold Coast hospitals that people are going to be flying in here for this treatment, because that's, I think, a very good policy. It's a good philosophy. UNM is the safety net hospital for the whole state. And I think that we need to be very responsible and responsive in this situation. So hence, UNM indirectly has made the decision that there's going to be no use by the fortunate few until therapies like this will be available to all. So that's my final point, and we still have a few minutes left for questions or comments. So Chris, I hope I haven't run roughshod over this very large topics here, but I hope it's been informative to your department.
Absolutely. That was an amazingly thorough presentation. Thank you so much. Dr. Delmore, I know you put one question in the chat room. Do you want to go ahead and?
Oh, great. Thanks, Dr. Knoefel. This is really great. I have so many questions. I just had a really straightforward question about, do you still recommend doing RPRs or VDRLs for workups when you're working up a patient for dementia?
Yeah, that's a good point. Yeah. Generally we do. So what's happened over the time I've been in dementia care is that we've come full circle I have come full circle from treating a lot of people who were young in the pre-penicillin era, where neurosyphilis could not be treated. It could be diagnosed, but it could not be treated. Now we're so now the pendulum, so most of those people are in that age cohort, they're no longer with us. They're deceased. But now we're having the pendulum is swinging over to individuals perhaps who have had HIV or have just not been. We don't think about neurosyphilis anymore, but generally that still is part of the evaluation. And again, it's obviously it's a one-time test.
Thank you. That's perfect.
Yeah.
Do you generally? Oh, sorry. Go ahead. Do you generally do genetic testing on your patients, and how do you think about that? I mean, I know in the early onsets you might do presenilin testing. Are we doing any like genotype type of driven treatment yet? Oh, no. Sorry, biomarkers type of driven treatment, with the quadrupled misfolded proteins and things like that. No,
not really, because the treatment, we don't really have any specific treatment for that. Right. And again, often, as you can imagine, that the treatments are going to drive some of this, going forward. But currently, we do not. There is a large study that's been going on for more than 10 years. I don't know if you've heard of ADNI, and that's the autosomal dominant neurological impairment. So those are the individuals who do have individuals already identified in their family who have those genetic changes, and so they're enrolling. This is out of St. Louis University. It's out of Washington University in St. Louis. They're enrolling entire families and following them over time. The families don't know what their genetics are, but the researchers do, and so they're really following them over time, and we're getting a lot of wonderful insights into that. But again, that represents like less than 1% of all individuals who have Alzheimer's disease. But yeah, there's a lot more sophisticated genetic analysis coming out, and I think there's a place in Sweden. Somebody in Sweden is identifying like a couple of hundreds of genetic variants that may predispose certain individuals. So we're going to be seeing a lot more of the genetics about it for sure.
Thank you. I do have one other quick question. I know Dr. Yaya has some questions in the chat, but what do you make of the new test that came out for doing the bedside, like the computer test to assess for dementia that was just approved? What are your thoughts on that?
Yeah, well, it's going to be interesting to see how. I'm just going to say it's going to be interesting to see how that plays out, because what that is that is actually a blood level of some of the markers. There's, as you can imagine, there's always going to be a range. We're doing spinal fluid analysis over here, and there is a range of individuals, some who are normal but have higher than expected tau in the spinal fluid, and of course the converse happens with the A beta, because the A beta is not getting into, the A beta amyloid is not getting into the spinal fluid because it's staying in the brain. I think we're really entering into a really exciting new era. There are a group of people who are doing plasmapheresis, and they're showing also an effect of if you get the soluble beta amyloid out of there, then that allows for more to come out in the spinal fluid and into the blood. So there's a lot of interesting things going on out there. So there's a question here in the chat about so what do we do to recommend restorative sleep? I'm sorry, I went right by that slide. The best is to eliminate such things as caffeine and any of those other offending substances, and then I start with melatonin, and you start with immediate release and titrate up. We have extended release melatonin these days, so we can combine immediate release and extended release melatonin, and really work with the family to get a good routine down. Use the melatonin preparations. If need be, we can layer on low dose clonazepam also, to see if that is going to assist. But in general, and of course, then you have to also deal with any kind of sleep apnea. I mean, that's another whole difficulty. That's another whole degree of difficulty. But generally, we work with the doses of the melatonin, which can really actually go quite high. The highest I've seen actually is 20 milligrams. That has proved to be beneficial in this one individual. And then, of course, the extended release as well is very helpful. And regarding the recommendations for the antipsychotic use, generally, I think there is a little, okay. So when do I use antipsychotics? I do use antipsychotics. I don't use them in Lewy body patients. I use them in some very few of my Alzheimer patients when they're having a lot of paranoia. Some of my Alzheimer patients have visual misidentification of their family members, and so they feel paranoid and threatened. So very low doses, I usually use quetiapine, can be very helpful and really can't change the course of the illness, but it can change the course of the symptom management significantly. And there's one other one here. Oh yeah, so yeah, I do use the antipsychotics. I can tell you I do not use them in Lewy body. Alzheimer, yes. Mixed dementia, yes. Vascular, yes. Not in Lewy body.
Thank you, Dr. Knoefel. I think we have gone a little bit over time. I thank everybody for sticking around. And Dr. Knoefel, thank you for a wonderful presentation.
Thank you for sticking around, and thank you for giving me that extra 4 minutes.